It also has a collagen fibers type 2, and that are mainly to counter the compressive force. So this is how the disc survives, and whenever the nutrition is compromised, the problem starts. So here in this slide, you can see the repeated trauma, micro trauma, fell from the bicycle or fell from horse riding. Those minor trauma cumulatively starts in a process, and then you have some genetic contribution and compromised nutrition. The key is compromised nutrition, because if you don't have balance of cell production with cell loss, then you start having the degeneration. And this tells you how the entire microenvironment is changed when there is degeneration starts. The discs are already hypoxic, and now there is more hypoxemia, and there is a lactic acidosis, and so now once the degeneration starts, the bad news is that it keeps progressing to it doesn't regress, it progresses. So you have calcified end plates, so nutrition is compromised, diffusion is compromised. There's a progressive imbalance between anabolism and catabolism. There is progressive loss of chondrocytes and proteoglycan and glycoprotein glycan. Now, just to understand the some specific parts of the stenosis. The D is the central part. This is mainly where the central canal stenosis is. C is a lateral stenosis, which is from the central canal to border the foramen. We call it lateral recess, lateral recess. And then there is a foramen, which is the letter B, and A is extra foramen. So just to understand, in correlate with the picture on the right side, where and how the nerves and or spinal cord can be compressed. The other very important structure we have to understand is the ligamentum flavum, and hypertrophy of the ligamentum flavum contributes to central stenosis. So here you can see the ligamentum flavum. When the ligamentum flavum, which is normally less than 3 millimeter, and when at that time your canal is more oval or more round, but it becomes a triangular when there is a ligamentum flavum thickening. And generally speaking, if it's more than 4 millimeter, that ligamentum is thick. Now, we have to understand the MRI studies do not correlate to clinical presentation. So even if you sometimes see the severe stenosis and patient may not have any symptoms, and that's quite possible. That poor correlation is important to understand, and it's important for us to treat our patients. Now, putting all this together, the contributors of the lumbar spinal stenosis is the narrowing of the spinal canal, central canal, the lateral recess, and neural foramen. Most commonly caused by the degenerative osteoarthritis and spondylosis, but that is the result of the progressive degenerative disc disease, because the height between the vertebra disc height narrows, and then it puts the pressure on the posterior column, and then you have osteoarthritis and other issues. The facet arthropathy and osteophyte formation also contributes. The osteophyte formation mainly contributes to either lateral recess stenosis or the foraminal stenosis. And then ligamentum hypertrophy, and then unfolding, because whenever you have a smaller narrow area between the vertebra, then there's an enfolding of the ligamentum flavum that also contributes to the stenosis. So degenerative disc disease, it's a low pressure disc. There is a more the loss of water. It's a more dry disc. It's a dehydrated disc, and there are some internal disc derangement and radial tears. There is a biomechanical effect and biochemical effect. Biochemical is because of the inflammatory process, and biomechanical, as we discussed in the past, affecting the joints and affecting the biomechanics of the lumbar spine. When the disc is progressive, this wide homogeneous disc in grade 1, and it continuously progresses, and you can look at the last picture to grade 5, which is dark in inhomogeneous disc with hypotense dark signal, and there is no really disc left at all. This is totally bone on bone. And so the good news is it takes decades for degeneration to progress. Up until almost the grade 3, the patient can be totally asymptomatic, and then 4 and 5, the symptom starts after it starts pressing on the facets and starts causing the foramen narrowing and the lateral recess narrowing. So if you focus on the treatment of this issue, then the most common treatment right now is kind of supposed to be gold standard is surgery. But the problem with surgery is that it doesn't really focus on the root cause, which is degeneration. It does help for symptomatic relief. You know, if you have a neuro deficit, it might decompress it, and if you have pain, because of instability, it can stabilize it. But the degeneration is not addressed. In fact, it causes more degeneration. We call it adjacent level disease, and that's actually something that we must understand, that all the treatment we are offering are not addressing the root cause, just the symptomatic relief. The only treatment that can change or address this cause is the regenerative medicine. This is totally a talk of the different time, but regenerative medicine has potential to offer and change the course of the degeneration. This is a Cochrane review that came out in 1999, and it talks about the treatment offered to a degenerative spine, and their conclusion was there is no scientific evidence on the effectiveness of any form of surgical decompression or fusion for the degenerative lumbar spondylosis compared to natural history, placebo, or conservative treatment. So you can understand that how much is we are paying for doing the surgery and then having the failed back surgery syndrome, and one thing leads to another. So for degenerative spine, it's quite possible that if you don't do anything, patient will end up giving the natural history, which is autofusion, and pain will be automatically limited. So I'm very strongly believe that unless there is a neurological deficit, patient should not go for surgery. And just for pain also, patient should not go for surgery because surgery may not fix the pain. So very quickly, lumbar stenosis, there are three areas: central stenosis, lateral recess stenosis, foraminal stenosis. And the causes we reviewed: ligamentum hypertrophy, ligamentum flavum hypertrophy, disc herniation, bulging, spondylolisthesis. There might be some coexisting contributors, facets and degenerative joint disease. There might be mordic changes. Mordic itself does contribute to symptomatology, but it does not contribute to stenosis. To define the stenosis, they looked at the area. If the canal, central canal, is decreased by 1/3%, then it is mild stenosis. If it is between 1/3 to 2/3, then it's a moderate stenosis. And when the canal is decreased decreased by 2/3, meaning 1/3 is only left, that is a severe stenosis. And this is where you see more triangular area. The similar definition is for the lateral recess stenosis. However, there is no special criteria for foraminal stenosis. And look at the radiological criteria. Central stenosis, it is you look at the AP diameter. If AP diameter is less than 10 millimeter, then it is the stenosis. And or look at the cross-sectional cutoff where 10 millimeter this way and 10 millimeter this way should give you more than 100 square millimeter. If that square cross-sectional area is less than 100 square millimeter, then that is stenosis. Lateral stenosis is based on the height. If height is less than 2 millimeter or depth is less than 2 millimeter, then it's lateral recess stenosis. Again, for foraminal, there are no specific criteria. So diagnostic evaluation of spinal stenosis. Problem is there is no gold standard diagnostic criteria. There is a history of neurogenic intermittent claudication. So your history, physical examination, and presence of NIC is what really makes you suspect the spinal stenosis. You also have to differentiate between the radiculopathy and neurogenic claudication. These both are totally different mechanism, and I will go over it a little bit later. Narrowing of spinal canal and foramen shown on MRI and CT does help us to make the diagnosis. However, the correlation is poor between what you find in the studies versus in a clinical presentation. Spondylolisthesis, whenever it's present, we should also always get the dynamic X-rays, flexion, extension, and look for the instabilities, because that's a part of the studies that we should do. So, what causes the root or cord compression? So, the spinal stenosis causes the ischemia of the nerve root by mechanical compression that we know. The mechanical compression is a couple of factors. One is when you stand, there is a venous congestion, and that diminishes the blood flow. So there is a congestion there. Second reason is there is a compression eventually causes decrease of the impulse conduction, and you get the neurogenic pain. The prolonged nerve root or spinal cord compression will give you motor deficit or sensory deficit. Clinical presentation, pain, numbness present when you are standing or walking, and pain and numbness relieved by sitting down and leaning forward. When also walking, leaning forward, we call it shopping cart sign. These are very typical of the spinal stenosis. The lumbar spinal stenosis patients suffering with the neurogenic claudication have limited mobility because they need to make frequent stops, and they don't like to really ambulate because they are afraid of getting pain and frequent stops, and sometimes they have to sit down and they will not find a place to sit down. So neurogenic claudication is standing, causes venous congestion. Extension of the spine causes overlapping of the lamina, and laminar ridge is when it overlaps and it contributes to canal stenosis. Resulting relaxation and inward buckling of the ligamentum flavum also contributes to stenosis. And when you walk, that increases your oxygen demand, and you get more ischemia of the nerve because your demand is more than the supplies. So this is how you get the neurogenic claudication. Neurogenic claudication and radicular pain sometimes can coexist, but it is very important to separate, because neurogenic claudication is because of the ischemia, radicular pain is because of the inflammatory process. And the treatment also changes. The neurogenic claudication, unless you provide the decompression of the nerve or canal, neuroforamen or canal, your symptoms will not improve. Here you can do epidurals, and symptoms can and can improve. So very important to differentiate claudication with radicular pain. When the spinal stenosis is advanced, patient gets a very severe bilateral leg weakness. Pain is not an issue here. It's because now pressure is so much that pain is gone, and now is weakness. And plus there is a bladder and bowel dysfunction, which is advanced spinal stenosis. In this situation, all bets are off and patient has to go for surgery. The Coda equina syndrome presenting with severe pain and neurological deficits is a neurological emergency. Now, when it comes to claudication, we should also have knowledge of differentiating neurogenic claudication versus vascular claudication. So if you look at here, the first two, increased pain with walking and ambulation, and pain relieved with sitting and lying, are common with both the condition. However, the vascular perfusion is poor in neurogenic, is good versus vascular, and perfusion would be poor. There would be weak pulses of dorsal spirits with the vascular. The pain is more pain with numbness. Here in vascular is pain more tightness and cramping. And a very typical presentation of neurogenic claudication is when you walk downhill, where you tend to keep the balance, you tend to lean backward, which is bad for spinal stenosis. So when you walk downhill, the symptoms increases. Here it doesn't matter whether downhill or uphill, symptoms are the same. In neurogenic claudication, back extension increases. Here in a vascular, it doesn't matter whether it's you have a pain, you have extension or flexion. The other thing which is very important is the recovery. The neurogenic claudication is very quickly recovers, and the vascular is an organic problem, it's a structural problem, it's a perfusion problem, so it takes longer time to recovery, while the neurogenic recovers very quickly. There is a consensus guidelines were published last year by a group of physicians. I was fortunate to be part of this group, where it's called MIST guidelines for the minimally invasive spine treatment. And these guidelines have come with some very important consensus points that I would like to mention here. This is the algorithm that we usually use for our spinal stenosis treatment. PT and non-invasive, non-medicinal first, then NSAIDs and adjuvants to epidurals, and to minimally invasive procedure, and then surgery. Up until now, we used to jump from if epidurals don't work, patient goes to surgery. But here now we have one more thing to offer before very extensive surgery. So the point one is the lumbar spinal stenosis treatment choice is dependent on the degree, level, and architecture of the stenosis and severity of the symptoms. Just because if you find the stenosis in your imaging studies, but symptoms are not severe, patient treatment should be based accordingly, not should be sent to decompression or something like that. The point 2 and 3, there are poor correlation between severity of spinal stenosis and imaging studies. And when possible, an interpretation of the MRI by the treating physician should be done. And this is one of our problem is we always trust our radiology colleagues, and they are usually very, very good. And most of them who read this are either neuro or spine expert. But somebody who is on call and is reading the studies, and his focus is more mainly different areas and not the spine, and it may not really help you that much. So you should be yourself reading the MRI study and measuring the thickness of the ligament of flava. The symptomatic lumbar spinal stenosis is a diagnosis that requires both radiologic evidence and the neurologic claudication. Just one of this is not good enough to treat the stenosis. Neurogenic claudication needs to be differentiated from claudication of other sources that we discussed. There is low quality evidence for NSAIDs or any other neuropathic medication and opioids for monotherapy in the treatment of stenosis. Now you can understand these are all elderly patients. They may be on different medication. Their tolerance to medication is very, very high, very low, and their side effects profile ratio is very poor. So they really don't do very well on the medications, and you have to be very, very careful because other medication and an interaction has to be addressed. This therapy should be employed judiciously and balancing the patient's individual risk and benefits when you treat them with the medication. There is a very little evidence supporting the axial bracing help. However, if there's a intermittent, there is an instability of the spine, sometimes the brace is helpful. Otherwise, usually brace doesn't help for stenosis. There is ample evidence to support that minimally invasive treatment of strategies for management. So now We have a lot of level 1, level 2 evidence in the minimally invasive options to offer before patient is sent to the surgery. And depending on the duration and the extent of the relief, the minimally invasive options should be offered to our patients. When performing the spinal intervention treatment, it is imperative to follow the described anticoagulation. Here it is more important because when canal is very narrow, very tight, even slightest amount of bleeding will be symptomatic. As you know, you need at least 30 to 40, sometimes 50 cc of blood in the spinal canal to be symptomatic. As you know, when you treat the epidural headache, I mean the spinal headache, you give the epidural blood patch, which is 20 cc. So usually 30, 40 cc is non-symptomatic, but after that it is symptomatic. And in spinal stenosis, if that ratio might be different, and you may get the symptomatic, even if there is a 20 cc of blood, you have to be more critical about managing the anticoagulation. So based on the systemic review, there is enough evidence for the mild, which is minimally invasive lumbar decompression, also called percutaneous image-guided lumbar decompression. Consensus committee has determined that there is a sufficient support to warrant level 1 evidence. And the same thing is for the spacer. This is about the spacer. There's the same evidence we have. So let's go back to now treatment options. So we start with the PTs, NSAIDs, lumbar epidurals, and then the change protocol with some minimal invasive. And that fails, then patient goes to the surgical decompression. The conservative management, these are some review. This is a journal article, and it says multidisciplinary conservative treatment program is most effective, not only for the discogenic back pain, but also for lumbar spinal stenosis. So it does provide some symptomatic relief in some limited patients, not all the patients. The systemic review of the physical therapy, same thing, physical therapy is commonly prescribed for patient for stenosis. However, we don't know which therapy is more effective. So if any kind of physical therapy is very important, even simple exercise program is very important. But if you don't do anything, that's not good because your muscles decondition, and deconditioned muscles are more painful. This is 2-year comprehensive medical management review, the study, and that reports that the comprehensive medical management did not result in sustained improvement in pain. And again, as we mentioned earlier, you have to understand the risk versus benefit ratio, because the patients in this age group have higher chances of the side effects and due to other medications also. Looking at the effectiveness of physical therapy and epidural steroid injection, both epidural steroid injection and physical therapy groups have demonstrated significant improvement in pain and functional in patients with spinal stenosis. All the scores of the functional improvement, functional assessment have improved. The epidural steroid and physical therapy both seem to be effective in stenosis for 6-month follow-up. This is a meta-analysis of the 13 RCTs looking at the epidural steroid. They use the epidural steroid, the local anesthetic with steroid, and local anesthetic alone. And in this situation, they found that there is no difference between the local anesthetic and the local anesthetic plus steroid. This is another study where the stenosis is very severe, and when you cannot get into transforaminal because of the foraminal stenosis, or the interlaminar because of the overlapping of the lamina, then you can do caudal epidural, and caudal epidural is very, very effective. Also, this is the RCT published in Pain Physician. The lead author is Dr. Manchikanti, who is chairman of the ACIP. And in this 100 patient, two groups, group one with local anesthetic alone, 100% lidocaine, and group two, lidocaine plus 6 milligram of betamethasone. And there was a significant relief and functional improvement in both. So in other words, if local anesthetic gives you the same pain relief, what is the need for using the steroids? So there are a group of physicians that they believe that we really don't need to use steroid for our procedures. Radio frequency, again, it has a role in spinal stenosis, not for the spinal stenosis per se, but one of the contributors is spondylolisthesis and contributes to your back pain. This is a retrospective review of close to 1,500 patients, 3-year follow-up, and they found is that 65% of patients out of 1,500 responded very well with the 65% pain relief for 6 months. So it does help, and you should offer to your patients to treat the back pain. This is the algorithm that we came up with after when we included the minimally invasive options to our algorithm. This was I was the lead author, and we published last year. And the reason is there are several minimally invasive procedures have been developed, and that has expanded our treatment options, and we should include those treatment options. The MIST guidelines that we talked about, that also recommends that we should include the minimally invasive options into our treatment algorithm. So I'm going to review some of the options. There are mainly 3 options available, and all 3 options are indirect decompression. What it means by is that it prevents the extension. So if you can prevent the extension, there is less weight load transmitted to posterior column, and your pain is less. And because of the preventing extension, you will not have a infolding of the ligament, and you will not have overlapping of the lamina, and there would be a decompression. So it is indirect decompression by preventing the extension. And there are 3 mainly, there are many products, but right now there are 3 products available. One is called the coflex, which is actually more interlaminar spacer. Then we have a Superior, and then there is another spacer called X-top. Now X-top was around many years ago, but it kind of fell out of practice because there were higher migration of higher posterior migration, and also the spinous process fractures. So people stopped doing this. There are some people still do it, but not as much as they used to. And also, the coflex and X-top is not offered by pain physicians. These 2 procedures are still done by the spine surgeon and not by interventional pain physician. Superion is the new one that just came out 5 years ago, and that is the option that we are offering. I do on my regular basis in my practice. It's very simple, takes 20-30 minutes. You can do, it's a FDA approved for 2-level decompression, and it's really very easy. I'll just go through the steps, so it works very, very well. This study is about interspinous spacer, and the study shows that it is minimally invasive, is effective, safe procedure, and should be offered to our patient. And I do believe that patients should be offered minimally invasive option before you consider any kind of very extensive surgery. This is also interlaminar spacer, a similar positive outcome with the pain and functional outcome with the spinal stenosis, again minimally invasive, and they should be offered. The Superion is my favorite. I do, as I said earlier, regular basis. It is also indirect decompression. It improves your pain, numbness, and cramping, and improves the neurogenic claudication. Your walking distance increases from few blocks to many blocks. It is FDA approved for mild to moderate. It is not approved for severe stenosis. And the reason is when stenosis is so tight, your canal and lateral recesses are only left 1/3 of the side, then this procedure will not help. So um, sometimes we do it depending your clinical judgment, and patient insists that patient wants to try before he goes to more extensive surgery. We do it, but it's not approved for severe spinal stenosis. Imaging studies are very important, and I mentioned everything. So it is outpatient procedure, no general anesthesia. It is IV sedation and local anesthetic. There are very low rate of procedure complication because the dissection is very, very limited. Small incision, no tissue or bone resection, just splitting the tissue, so there is no really no blood loss. Very reduced operating time, as I said. I usually in 30 minutes I do 2-level spacer without any problem. There is no destabilization of the anatomic structure. Mainly, this is compared to the surgery. Whenever you do a posterior element removal, which they do in the decompression, your weight-bearing ratio is changed, and this is one of the reasons why most of patients, even if you decompress, they continue having pain. They does not limit the future treatment. If there is any complication, fracture, migration, or anything, it does not limit the future option for the surgery. And clinical improvement is comparable to the gold standard, which is laminectomy. So something I don't know it is available anywhere other than America, but if similar product is available there, I very strongly recommend to learn and do this because it's very, very simple, especially for us because we are not needle jockeys. We don't just do epidurals. We are interventional spine expert, non-surgical spine expert, and we see things differently than how surgeons see. We always believe into minimally invasive, less trauma, and less uh, harm to the patient. So this is the patient positioning is very important. Heavy sedation, define your level very precisely, small incision in the midline at the supraspinous ligament. Use some dilators, 1 and 2 dilators advanced to the tips approaches the dorsal aspect of the facet joints, and then you use called the measuring gauge, and measuring gauge will tell you the size of the implant. This is available in 4 sizes: 8 millimeter, 10 millimeter, 12 millimeter, and 14 millimeter. So that you will decide by using the pressure gauge. And then you insert the gauge and load the implant and deploy it. It's very, very easy to do it. I have just a presentation, diagrammatic presentation of the procedures. Position is very important. Put some pillows to reduce the lumbar lordosis and increase the space between the transverse processes, midline incision, and then put the dilator. Any instrument that you do should be done in a lateral fluoroscopic view. You don't just like um, uh, uh, you guys all do the endoscopic discectomy. It's so important to really have lateral view when you advance your instruments. And um, in 5-year study, there is one complication that has been reported, and that complication was intrathecal perforation, and that was I don't know the name of the surgeon, but that was done by a surgeon, and he said he's so confident that he doesn't need lateral view, and he kept advancing, and then there was a disastrous complication of the intradural puncture. So this is the second dilator. So the dilator, you put the pressure gauge. This measures the distance between the spinous processes. You load the implant. After you load, you put the same area through this tube, and then you deploy it. And this is how it's going to look like in a lateral view and AP view. You very nicely placed, the implant between 2 spinous processes. This is my first patient I did 4 years ago, and I was very happy because this was she couldn't even stand, could not walk. She came to my office in wheelchair, and when she came for follow-up, this is 7 days after follow-up, and you can see she walked in no wheelchair and she was standing straight. So there is a lot of symptomatic relief with this procedure. Bleeding, infection, ineffectiveness, you have to be careful because you cannot promise that everything will be 100% better. You have to be careful, sometimes it may not work. Dural tear, we just put it here because it's part of the study, but dural tear is not an option. It cannot happen. You have to advance your instruments in lateral view. Device migration is very important because the implant can migrate posteriorly. But other two complications very important is the fracture of the spinous processes and the fracture of the spinous, the spacer device itself. So some of the tips to understand DEXA scan is important to know the extent of the osteoporosis to minimize the chances of the spinous processes. If patient has, DEXA scan will give you individual extent of the fracture risk, and that will help you to make the decision. Other very important thing is the spondylolisthesis. If your spondylolisthesis is more than grade 1, then you cannot do it. But even grade 1, if you have instability in more than 3 millimeter, you should not do this procedure because then you will have posterior migration. So this is a very similar thing I talked about. This is the DEXA scan. It gives you individual fracture risk, neck or femur or spinous processes. So it helps you to do the diagnosis. The other two you have to is a gracile spinous processes is a very thin spinous process. If your superior to inferior dimension is less than 20 millimeter, is a very thin spinous process, has a more risk of fracture. And kissing spine is where the process is so close that you cannot do it. Also very important that it has to be placed. Now this is not properly placed, is way behind. It should go as close to the posterior border of the facet joint. So you have to tap it in and close to that. So this is a proper placement. This is not a proper placement. Then this is a 5-year durability standalone study. 80% improvement in leg pain, 65% back pain, and 65% improvement in ODI. For interest of time, I'm just going to move a little bit faster. The same thing, the 5-year data, 42% for this is a claudication score for symptom severity. This is a physical presentation, and so different domain of the intermediate claudication questionnaire are also improved, and again, VAS score of pain and leg. The superior and the extra were compared, they are actually pretty good together. However, the back pain and axial pain was better with the superior compared to X-top. So you can see here, the axial pain was better and the patient satisfaction was better with the superior as compared to X-top. This is compared to the gold standard laminectomy. You can look at the back pain is improved more than the surgery. Leg pain is improved more than 70%. 51% ODI more. So all the parameters are much better with the minimal invasive procedure at 2-year follow-up. So it is very important to realize. Now, very quickly, I know I'm out of town, but I'm going to review very quickly about percutaneous image-guided lumbar decompression. This is a direct decompression because you actually remove the part of the ligamentum flavum with a very small portal. You pass the ronger and the tissue forceps, and you remove the part of the lamina and remove the part of the ligamentum flavum. So it is debulking and laminotomy procedure done through a simple portal 5.1 millimeter portal. It is outpatient, the same as done under IV sedation, and there is no complication. Very similar to the spacer. A safety mechanism for this procedure is your contralateral oblique, because you put your gun barrel view parallel to your lamina, and you do the epidurogram. That will save you going into the deeper deeper into the epidural space. So this is your safety mechanism. Procedural step, you do an epidurogram before. Here, this is a diagrammatic cartoon animation. You can see the epidural is blocked here. And then what you do is you put the portal, and through the portal, you use the ronger for laminotomy and tissue debulking forceps for the debulking of ligamentum flavum. And then you remove the part of it. And then you see the epidural is now improved. So this you must see at the end of your procedure. If your epidural is not improved from pre-procedure, then you might need to remove a little more tissue. The Midas and Core study is a very famous study. They looked at the 6 months and 1 year results after the procedure. Here you can see they compared it's a randomized controlled trial compared with epidural steroids. So if you look at here, the orange is the epidural steroid and the blue is mild. And in 6 months and 1 year, you have better results with the mild procedure as compared to epidural steroids. And this is the similar study, same study in a different domains of the ZCQ and also pain and back pain and leg pain. So there is always a question about which one is better, a mild PILD, mild or interspinous spacer. And these are some of the differences. One is the indirect decompression is interspinous spacer, and the mild is the direct decompression. It improves the symptoms due to anything, spinal canal stenosis, lateral stenosis, or foraminal stenosis. This is mainly for the central stenosis. However, the lateral study has shown that even if a patient has a foraminal stenosis and lateral recess stenosis, this procedure potentially improves those areas too. There is an implant here. In mild, there is no implant, and you can do up to grade 2 spondylolisthesis. It is contraindicated for osteoporosis more than a Z-score of minus 2.5, and that will increase the chances of fracture, so you don't do it. And here, osteoporosis is not an issue. Contraindicated if the slippage in the spondylolisthesis is more than 3 millimeter, you don't do it. Here, there is no issue. Also, the interspinous spacer cannot be done at alpha S1 because you need two spinous processes to place the spacer. So unless patient is L6 vertebra, you cannot do this. And here you can do it. So there are some subtle differences that you can do. And here I end my presentation. I thank you for listening to me, and I'm open to any questions.
Thank you so much, sir, for the lucid presentation. I'm so thankful that you could make it, and you have given such a wonderful presentation, and you have gone through so many options of minimally invasive treatments of spinal canal stenosis, especially the spacers. I think it is really nice that there are different types of spacers and how they're indicated, where they're not indicated. I really want to thank you, sir, because I know that how difficult it was for you to, even till morning, it was not decided that you could make it. But I'm so thankful that you made it a point to come in spite of your health issues. And
one of the things, Pratibha, you can trust me is on my commitment. If I commit, usually I don't back out.
Yes, sir. I think that's one of the...
Thank you, Dr. Diwan, for a very excellent presentation. Thank you, Dr. Diwan.
Thank you so much.
Yes, so that is one thing I really feel that there's a lot to learn from all of you. Each one has their own specialty. And this is one thing I've learned, that in spite of having problems, how to keep up your commitments. So actually for this presentation, we won't have questions, sir, because the questions are going to be followed by the tournament, the pain brain tournament that we have after following your lecture. So I would like to request